Hi, everyone. My name is Dr. Alyssa Memmini. I am an assistant professor here at the University of New Mexico in Albuquerque, New Mexico. I'm so excited for the opportunity to present to the New Mexico Athletic Trainers Association annual meeting. Today, I'm going to be talking about concussion assessments. The title of my talk is How Many Fingers Am I Holding Up? Assessing Vestibulo-Ocular Disturbance Following Sport-Related Concussion. Very briefly, I just wanted to give an overview of what to expect from my lecture today. First, I'm just going to give kind of a high level, just brief discussion really on the neuronal effects following sport-related concussion. Then I'm going to go into the difference between vestibulospinal and vestibulo-ocular systems because they are a little bit different, even though they are somewhat intertwined. We'll talk about updates to the sport-related concussion assessment domains based on the 2024 NATA bridge statement. Then I'm going to actually go ahead and explain the vestibulo-ocular motor screening, also called the VOMS. And at the very end of my lecture, I'll have a PDF document for you to use as a tool in your clinical sites if you want to use this moving forward for your concussion, either assessment or management strategies. I have a video of our current level 1 MSAT students who are going to do the actual VOMS demonstration. And then I'm going to just briefly talk about some of the VOMS literature and how this is advancing our concussion, both assessment and management. Moving into the learning objectives following this lecture, participants are going to be able to first describe the vestibulo-ocular and vestibulospinal systems and really how they're affected following sport-related concussion. In addition, we'll talk about common symptoms associated with vestibulo-ocular disruption following concussion. And then lastly, you'll be able to actually apply the VOMS assessment tool at your clinical sites, again, either as an assessment or a management tool to help improve patient outcomes. First, I wanted to just, again, give a very high level discussion about what's occurring immediately after the head impact. Remember, a sport-related concussion can occur from either a direct or indirect hit to the head, neck, or body in which the forces are transmitted up into the brain. And there's a lot of different things that are happening within the first 24 to 48 hours post-injury. And that's why we want our athletes to be resting, both physical rest and cognitive rest. So initially what we see is that potassium starts to leak out of the cell, and then we see calcium rapidly go inside the cell or influx. There is also what we call a glutamate or excitatory response that can occur, as well as some axonal stretching. And this oftentimes relates to some of our clinical correlates. So this can include slowed or decreased reaction time, sensitivity to light or noise, as well as migraine headaches. And those are some of the more common symptoms that we see following concussion. But we know that there are a lot of other symptoms that aren't as super specific as those that could be attenuated to concussion. And so what happens when we hit our heads, or again, if it's a hit to the body and those forces are transmitted up into the skull, we can see some disturbances into some of those neuronal pathways. So on the left-hand side here, this was one of the hits that Tua had from the NFL a couple of years ago. And then on the right-hand side, this is just an image of the brain. So the top portion of the picture, that's going to be our cerebral cortex. And then the blue lines are just indicating some of those neuronal pathways. So we can see that once we have an injury to the brain, it can cause disruptions in those axonal pathways, either up in the cerebral cortex or a little bit lower down into the brainstem, and then so forth into the spine. First, I'm going to talk about the vestibular system. So our vestibular system does a really great job in maintaining postural stability or balance, as well as proprioception, or where our body is in space. And the vestibular system is comprised of several different structures. First, we have the inner ear, which is going to be comprised of these small structures here. You can see these are blown up in the blue image here. The most outer portion where our auricle can be found, that's the outer ear. We have our middle ear, which is this pink area. And then again, this is the inner ear here. So there can be some inner ear disturbances following head-related trauma. Briefly, the utricle, so that's going to be this kind of big blue blob in the center of the inner ear. That's really in charge of detecting horizontal motion of the head. We also have the saccules, which is just inferior to that, and that's going to be in charge of detecting vertical motion. Within both of these organ systems, there are really teeny tiny crystals that can cause the hair cells, or really, really tiny cells within both of those organs, to shift. And what happens is it sends some sensory information to the brain. And there's a number of different responses that can happen. During head movement specifically, some of that fluid will shift, causing the hair cells to move and send some of that sensory information to the brain using cranial nerve 8 or the vestibulocochlear nerve. Within the vestibulospinal system, so again, we have our vestibular organs within the inner ear, and we can see that they communicate with the brain through the vestibular nerve here. And this is just an image of the brainstem. There are two main tracts that I want to talk about today. The first one is the medial tract of the vestibulospinal system. That's going to innervate muscles of the head and neck. We can see here it's the most medial. And then we have the lateral tract, which innervates muscles of the extremities. So when you're moving your head, both of these tracts send signals to other parts of the body, either their head and neck or the extremities, to activate some of those anti-gravity muscles and maintain that posture. When we move into the vestibulospinal system, particularly on that medial side, I really wanted to emphasize that this helps with facilitating head and eye coordination. So we can see that as the owl is shifting his head, the eyes remain stabilized within the skull. So it's that synchronization between the eyes and the head so that the eyes aren't lagging behind. If there is damage to the vestibulospinal system, particularly those medial systems, that's going to cause damage to the eyes themselves, causing the nystagmus or the bouncing that we can see sometimes post-concussion. Now I'm going to spend most of my time talking about the vestibulo-ocular system. So the vestibulo-ocular system keeps your eyes fixed on an object while the head is either moving in a vertical direction, horizontal direction, or diagonally. So both looking at the horizontal and vertical vestibulo-ocular reflex, which I'll talk about in the next couple of slides here. We can see that these systems, they start up into the brainstem, and then they're going to go up and innervate some of the ocular muscles. So they're going to be in charge of, again, keeping those eyes fixed on an object, whether the head is moving in a vertical direction or a horizontal direction. Here we can see in this cartoon that the character is able to keep his eyes stable while the head is moving in a vertical direction. So this will be what we call the vestibulo-ocular reflex, or the vertical VOR. You also have a horizontal VOR, so we can see as the woman's head is rapidly shifted to the right and the left, the eyes are able to remain stable on the image in front of her. And again, this image here, promise you don't have to memorize it, but this is just kind of a nice visualization of the different neuronal pathways that kind of come into play from the endolymph, from the inner ear, and how they will innervate some of those structures into the intraocular muscles. As you can imagine, we've come a long way from the initial concussion assessments of, how many fingers am I holding up? We have a much more comprehensive understanding of how concussion can affect several different domains. And I'm just going to briefly talk about some of the updates that we've seen within the most recent NATA 2024 bridge statement on sport-related concussion assessment and management. Briefly, a lot of the literature has shown that baseline testing actually does not need to be included in a concussion management plan unless it's already established potentially by your school or institution, state legislature, sporting association, or any other relevant guidelines. Several of the international groups, medical organizations, and other independent investigations have actually shown that annual baseline testing may not be necessary to optimize post-injury care. We recognize that clinicians, particularly athletic trainers, are oftentimes very much overwhelmed with the number of student athletes that they have to conduct with the pre-participation examinations, and conducting maybe a SCAT-6 at the beginning of every sports season may not be feasible. So Again, follow what your institution, school, clinic, or state legislature recommends. But in general, we don't necessarily need to have a baseline assessment. If I were still practicing clinically, I probably would like to get a just general baseline understanding of where my patients may be, just because that does help a little bit with understanding potential risk for more prolonged recoveries, but it's certainly not necessary. And then as a reminder, if the baseline is conducted, you really want to administer these assessments in accordance with the testing guidelines. So if they are, assessed on the sidelines for their baseline, they also need to be assessed on the sidelines post-injury. Or if it's an office assessment, it needs to be another office assessment post-injury. Again, as researchers, we recognize that this is probably not clinically feasible, but for the purpose of developing these tools, that's usually what they recommend. Within the 2024 bridge statement, there was a really nice kind of overview of the various domains that have to be included within a concussion assessment. So this includes first taking a very thorough concussion history, as well as understanding their personal or familial medical histories. We also see that individuals with pre-morbid or pre-injury mental health disorders such as depression, anxiety, ADHD may have a higher risk for prolonged recovery. So if we can identify those risk factors sooner, it might be able to mediate some of those recovery timelines. We also see that they're really recommending a thorough symptom assessment, which we see within the SCAT symptom tool, a neurostatus screen, which is typically conducted using the Standardized Assessment of Concussion, or SAC, as well as an upper quarter screen and cranial nerve assessment. We also strongly recommend using a motor control and balance assessment. This could be done either using the balance error scoring system, the BESS, or the modified BESS. We'll also see within the SCAT and the SCOT, there are updates to some more advanced postural stability assessments, such as the single and dual task tandem gait. Most of the remainder of my lecture is going to be really focusing on vision and vestibulo-ocular disturbances. So this can be done doing some of the cranial nerve assessments as well as conducting the VOMs, which I'll demonstrate in a couple of slides. And lastly, and I think sometimes a bit overlooked, I think we do a really good job at that initial assessment to assess cervical spine range of motion. But we also found that individuals that aren't continually assessed on C-spine range of motion could be at risk for prolonged recovery. So again, if you aren't doing this on your reassessments, I would strongly recommend that you take a look at the C-spine range of motion to see if there may be some deficits that maybe have been overlooked. So again, I'm going to be focusing kind of the remainder of my lecture on this vision and vestibulo-ocular disturbance and some things to be mindful of. This is just a friendly reminder to please make sure you're conducting your cranial nerve assessment. On the left-hand column, I have the number and the name of the cranial nerve. In the middle column, this is a mnemonic that I give to my students. If there are any Harry Potter fans, you're welcome to go ahead and take this. I think there's a whole Wikipedia page on various mnemonics for the cranial nerves, but this one I felt was the most school appropriate. So it's on, they traveled and found Voldemort guarding very ancient Horcruxes, going from olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and ending with hypoglossal. In the most right-hand column, these are some of the just very general functions. Again, it's just a reminder to make sure that you are conducting those cranial nerves. As I move into the vestibulo-ocular motor screen, this is where cranial nerves 3, 4, and 6 are primarily assessed. We do see a little bit of vestibulocochlear, cranial nerve 8, but remember that's more of the vestibulospinal or balance component. And this, and within the VOMS assessment, we're really trying to target the vestibulo-ocular system. Again, these next couple of slides are kind of just reminders. So there are updates to some of the concussion tools. The first one being the child and adult SCAT-6. So that's the Spark Concussion Assessment Tool. It takes about 10 to 15 minutes to complete. Again, if you are doing this in office pre-injury or at baseline, we do recommend that you conduct it similarly in a similar setting post-injury for the best outcome. If you are working with patients who are ages 8 to 12, we recommend using the child SCAT. Anyone 13 and up can be can be administered the adult scat. You can use the scat for about a week post-injury. However, optimum utility occurs within the first 3 days post-injury. As you transition between this scat and the scope, just kind of keep that in mind. And there really was intentional overlap between these two tools. So as you are working with your patients, we recommend that you start to slowly transition to the scope, really within that first week, but ideally 3 days post-injury. And what's really nice about the SCAT is it includes a lot of those clinical domains that I mentioned before that really need to be incorporated within a concussion assessment to understand the holistic experience or holistic symptoms that are affecting our patients. Here's an overview of some of the components of the SCAT. We can see you take a very thorough concussion history, noting some observable signs, especially those red flag signs that might warrant activation of the EAP. Cervical spine assessment, as well as the Glasgow Coma Scale, if it's a more severe injury or if their injury is worsening into something a little bit more serious, like a more moderate to severe TBI. There is a brief coordination and ocular motor screen, but again, I'll kind of talk more about that when we get into the scope, which is a much more comprehensive evaluation. The classic Maddox questions, asking them about their background in competition, as well as their concussion history. There's the symptom inventory, SAC, BES, time tandem gait, which is new this year, and then, of course, everyone's favorite, the delayed recall. As they are transitioning out of that acute phase post-injury, again, we really encourage our clinicians to consider using the SCOTE. So this is the Sport Concussion Office Assessment Tool. We do recognize that this tool takes a lot longer than a SCAT. This takes about 30 minutes or so front to back. There are different components that are required, recommended, and optional. So that's going to go in order of blue, green, and orange. So you certainly don't have to do the full SCOTE assessment, especially if you notice that maybe they do have true vestibulo-ocular deficits, but everything else looks okay. You can just kind of choose which pieces that you really want to emphasize within your concussion assessment or management strategies. Similar to the SCAT, there is both a child and adult SCOTE. Children ages 8 through 12 should use that child SCAT, and then anyone 13 and up can go ahead and transition into the adult SCOTE. And within these tools, we recommend that you use them up to about 30 days post-injury. If you have patients that are taking longer than 30 days, they probably require some form of referral anyway. So you might be getting a more direct rehab program, either working with a PT or an OT, depending on how your patient is presenting. As I mentioned, there are several different SCOTE components. Again, this does take a lot longer, so I do recognize that this is probably something you can't conduct every day. But again, you can kind of pick and choose which sections make the most sense based on the patient. We can see it takes a much more holistic kind of overview of their head injury history, as well as if they have any predisposed conditions like neurological, psychological, psychiatric, or learning disorders that could put them at risk for prolonged recovery. We want to make sure that we're getting a good inventory of their current medications and if that could maybe be a contraindication during their concussion recovery. In addition, we incorporated the orthostatic vital signs, so looking at blood pressure, heart rates in both a supine and standing position, and this could identify potentially some disruptions in heart rate variability. Moving into the right-hand column, we see again the time tandem gait and the MBES looking at postural stability deficits, the dual task gait, and then of course the VOMS, which I'll talk about over the next couple of slides. What I also thought was really helpful as a clinician is that there are some brief scales that can help us identify patients who might be at risk for anxiety, depression, and maybe some sleep disorders, either pre or post-injury. So again, this is kind of a nice way to identify whether or not we need to really push our patients into a referral quicker, or if this is something that maybe we can manage in clinic, given all of our other responsibilities. Okay, so now I'm going to talk about the VOMS assessment. So there are several different components of the VOMS. First, the clinician is going to ask kind of like the baseline measures, and they're going to ask the patient to rate the following symptoms on a scale of 0 to 10 at baseline, and that includes headache, dizziness, nausea, and fogginess. Then they're going to go through each of the tasks with their patient. And then after every task, they're going to ask the patient, can you please rate those same symptoms, headache, dizziness, nausea, and fogginess on a scale of 0 to 10? 0 means completely normal, no symptoms. 10 being so bad, take me to the hospital. It's important to note that you should not just use the VOMS assessment to determine whether or not somebody has a concussion. This has to be used in association with other concussion tools like the SAC, BESS, maybe the impact neuropsychological screen to determine concussion status. However, the VOMS could be really helpful in identifying some of the deficits that maybe some of these other assessments can't quite pick up. The VOMS, as I mentioned before, was not included in the SCAT because, again, we want that to be a really rapid tool. And so incorporating more tests just requires more time on the sidelines. So we needed something a little bit quicker. However, in the SCOT, there is a modified VOMS, which I'll talk about as we kind of progress through the VOMS assessment itself and how that could be a really helpful tool in clinic. And it's a little bit quicker than the full VOMS assessment. Okay, so let's break down the VOMS assessment. So first is what's called smooth pursuits. So the clinician is going to sit about 3 feet away from the patient, and they're going to move their finger from side to side. So this would be first horizontal smooth pursuits, and then vertical up and down. For the horizontal smooth pursuits, the clinician is going to move their finger a foot and a half to the right, and then a foot and a half to the left. When they bring their hand back to the right, that would be one set. So here to here would be one. They're going to do that 2 times. Then for the vertical smooth pursuits, they're going to raise their finger a foot and a half above and then a foot and a half below. Again, they're going to do 2 reps with that. Once they've done both the horizontal and the vertical smooth pursuits, they're going to ask their patients again, can you please rate those 4 symptoms on a scale of 0 to 10? Next, we have the horizontal saccades. So saccades just means the rapid eye movement. So the clinician, again, is sitting about 3 feet away from their patient. They're going to have their fingers up about 3 feet apart in width, and they're going to ask the patient to look as quickly as they can from the right finger to the left, back to the right. That would be 1 repetition. The patient is going to do that 10 times, again, as quickly as they can, looking from the right to the left to the right. And then again, we're going to ask them about their symptoms. Similarly, we have the vertical saccades. So the patient is going to sit 3 feet away. Clinician will have their hand 1 foot above the middle and then 1 foot below. And then they're going to ask their patient to look up and down as quickly as they can for, again, 10 repetitions. Once they have completed those 10 repetitions, they'll go ahead and rate those 4 symptoms again. The following task is called near point convergence. And so you're going to hand the patient either like a popsicle stick or a pen that has an X at 14 size font. And the patient is going to hold it straight out in front of them. They're going to slowly bring the pen or the popsicle stick as close as they can to the tip of their nose. Once they see double or 2 X's, then you're going to ask them to stop. And then you're going to measure the distance from the tip of their nose to where they stopped. If their vision gets blurry, that's okay. They can keep going. However, if they start to see double vision, then we want them to stop. We'll ask the patient to conduct that 3 times, and then we will denote that distance after each time and take the average. Once they've done those 3 sets, we'll go ahead and ask them about their symptoms again. All right, the last 3 include horizontal, vertical VOR, and then what's called the visual motion sensitivity. So remember, the vestibulo-ocular reflex can occur both in the vertical or horizontal manner, and we want to make sure that the patient keeps their eyes fixed on the popsicle stick or the pen, whichever one you choose, while they're moving their head. So first, with the horizontal VOR, clinician will stand about 3 feet away. You can also have the patient hold the popsicle stick or pencil out in front of them as they move their head. For the horizontal VOR, they're going to shake their head from side to side at 180 beats per minute. So they'll go right, left, right. That would be one, and they'll do that 10 times. They want to keep their eyes fixed on the X that's on the pen or the popsicle stick. Then you'll go ahead and ask them to rate their symptoms. Then they'll move into the vertical VOR, where they'll have, again, their arm out in front, or the clinician can hold the item out in front of them, whichever is more comfortable. And then they're going to shake their head up and down. So up, down, up would be one. Again, it's going to be 180 beats per minute, and they're going to do that 10 times. As a clinician, you're going to go ahead and ask them to rate those four symptoms. Lastly, we have what's called the visual motion sensitivity test. And you actually want to do this test in one of the more busy or like bustling parts of your athletic training facilities, where there's a lot of patients kind of moving around, doing rehab, coming in and out of clinic. We really want to kind of disturb the vestibulo-ocular system and increase their symptoms. So we're going to have our patients stand, and they're going to keep their arm straight in front of them. I like to have them bring both of their arms together, and they're going to rotate their entire torso to the right and left at about 50 beats per minute. So you can use a metronome, or you can use like a YouTube app to keep track of the beats per minute for the VOR as well as the VMS. And they're going to rotate 5 times. So right, left, right would be one. They'll do 5 repetitions of that, keeping their eyes fixed on their thumb as they're rotating. And again, we want to make sure it's in a really busy area, so there's a lot of background movement. Once they've done the 5 repetitions, we'll go ahead and ask them to rate their symptoms. On the next slide here, I have a video demonstration of our students actually going through the VOMS assessment. I'm not totally sure if the audio is going to work, so I'm just going to go ahead and narrate as our students are going through it. Christopher Parrish is the patient, and Jade Skaggs is our clinician. So at the very beginning of this assessment, as a clinician, you want to just kind of explain what you're going to do with your patient. It's important to let them know that there is a possibility that this might be increasing their concussion symptoms, because we're really kind of trying to disturb the vestibulo-ocular system. But if it becomes too intolerable, we'll of course have to stop the assessment early. We can see that Jade is sitting 3 feet away from her patient, and she's going to first start with the horizontal smooth pursuits. Again, we want to do 2 repetitions to the right and left, about a second per movement. And then she's going to go into her vertical smooth pursuits. Again, taking about a second to go a foot and a half above, and then another second to go a foot and a half below. We'll do that 2 times. At the end of those 2 repetitions, we'll go ahead and ask them about their symptoms. So they'll do horizontal and smooth pursuits together. Now we're moving into the horizontal saccades. So again, the patient is going to look right, left, right, only using their eyes, so not moving their head. And they're going to do that 10 times. Now we're going to ask the patient to rate those symptoms before moving into the horizontal saccades. They're going to look up, down, up. That would be 1 repetition, and he's going to do that 10 times as fast as he can, only moving his eyes, not moving his head. Next, we're going to go into near point convergence. So the patient has a pen in front of him with an X that's denoted using a Sharpie or pen and a little bit of athletic tape. The patient is going to hold the pen out in front of him, and he's going to slowly bring the pen to the tip of his nose. So the clinician is going to ask him to bring that pen as close as he can until he starts to see double vision. As a reminder, if he sees blurry, that's okay. It's really once he starts to see that double vision that we would want to take that measurement. Again, she's taking the measurement from the tip of the nose to the pen. Patient will do that 2 more times, and then we'll go ahead and ask them about their 4 symptoms. The next component is the horizontal vestibulo-ocular reflex. So the patient's going to hold the pen or popsicle stick straight out in front of him, and he's going to move his head side to side at 180 beats per minute. Right, left, right would be one repetition, and he's going to do that 10 times. He's going to keep his eyes fixed on the popsicle stick or pen as he is rotating his head. We'll go ahead and reassess those four symptoms. And now he's going to move into the vertical vestibulo-ocular reflex. So he's going to keep his eyes fixed on the X as he moves his head up and down into a yes-no motion. Again, this is at 180 beats per minute. The last component is the visual motion sensitivity test, or VMS. So you want your patient standing, and he's going to put his arms straight out in front of him. You can do one arm or two, and he's going to rotate almost like thoracic rotation. And he's going to rotate right, left, right. That's going to be one repetition. We'll do that 5 times. And it's going to be at about 50 beats per minute. Remember, you want to do this in a busy part of your clinic where there's a lot of background movement. Sometimes patients have a really hard time kind of keeping on beat. So it's okay to kind of cue them and say, go faster, make sure that you're hitting the beat as you are rotating over. Once you've done with, once the patient has completed the VMS or visual motion sensitivity, again, we'll go ahead and rate their symptoms. The next kind of chunk of slides, I just wanted to talk about the VOMs in contemporary concussion literature. This first study I'm going to talk about was actually how the VOMs was generated. So this was conducted by a group of outstanding colleagues out of the University of Pittsburgh who really are in charge of identifying some of these vestibulospinal and vestibulo-ocular deficits in our concussion patients and bringing this knowledge to the forefront about how this could be maybe affecting some of our patients. So the study rationale for this was that they found that vestibular impairments are very common after sport-related concussion and actually might impede recovery trajectories. There really aren't any other tools besides the VOMs, especially before this study where it was actually created, to identify some of these deficits, which could have maybe contributed to these post-concussion persistent symptoms. They also found that dizziness is one of the top symptoms behind headache among our concussed patients, which really could be an underlying disturbance to the vestibular ocular system itself. Importantly, disruption to the vestibulospinal system, remember that's in charge for balance, can show in like the MBES, if you're doing the Romberg test, anything that really is looking at balance deficits. But dysfunction or disruption to the vestibular ocular system might result in that dizziness or maybe visual instability that we oftentimes see with our patients. As I briefly mentioned before, some of the clinical tools for balance impairments may not effectively be measuring some of those vestibular deficits. And really, it might be coming from the vestibulospinal system versus the vestibular ocular system. Most of the athletes that they had studied really found that they were reporting dizziness, but also did not present with concomitant balance deficits. So it might really kind of point to the disruption in the vestibular ocular system. Importantly, because the vestibulospinal and vestibulo-ocular systems don't share identical neuronal circuitry, meaning there are different pathways to and from the brain and the spinal cord, it is possible to have impairments of the vestibulo-ocular system without impairments to the vestibulospinal system and vice versa. So really the purpose of this investigation was to describe and provide some initial data for the internal consistency of a new brief clinical screening tool to assess vestibulo-ocular motor impairments and some of the symptoms after sport-related concussion. And what they did was they took about 64 patients who were diagnosed with a sport-related concussion within the first 3 weeks, and then they compared some of the results to a cohort of about 78 healthy individuals. And these were some of the things that they found. In table 3 above, we can see that there are all of the components of the VOMS assessment. and they found that there was a significant relationship with the likelihood of concussion. As we can see here, all of the p-values are well below the a priori threshold of 0.05, and they have some pretty high odds ratios. So for example, we can see that with, for example, the horizontal vestibular ocular reflex, there was an odds ratio of 3.89. And what this means is that individuals who presented some symptoms with the horizontal vestibular ocular reflex, keeping the head fixed, moving side to side in a no pattern, um, they found that they were about 3 times more likely to be diagnosed with a concussion. So all of these tools had a really, really high probability of being able to identify patients with concussion. When we look at this bottom table, this is predicting concussions in healthy controls. And what they found was that the analyses demonstrated all VOM scores accurately identified patients with concussions. So we can see here with the positive likelihood ratios, going back way back to your diagnostic accuracy classes, remember that a positive likelihood ratio is it's really a kind of a nice tool to use the sensitivity and specificity to figure out how to identify patients who might have a certain condition. If the positive likelihood ratio is above 10, it's a really, really good chance that we can identify patients with concussion. And we can see all of these, except for near point convergence, which had about a medium positive likelihood ratio, were much more likely to, again, identify those patients with concussion, which was really promising. We also see here the clinical cutoff score, so that's going to be in this column here. And so a clinical cutoff of 2 or more symptoms on any of the VOMS items, so if they're rating them, like let's say headache from a 2 out of 10 to a 4 out of 10 after doing one of the components of the VOMS, indicated a high positive likelihood ratio, meaning that there's likely some deficits that are coming from the concussion when we compare it to our healthy controls. We can see that with the near point convergence, an abnormal finding would be about 5 or more centimeters between the tip of the nose and the pen or the popsicle stick during that near point convergence testing. And this is why we use those clinical cutoffs as we're doing the VOMS assessment. I wanted to also talk about the CARE Consortium. So this is the Concussion Assessment Research and Education Consortium. This is a extremely large concussion study. It's actually the largest concussion study to date. It's comprised of over 30 institutions across the US, including both civilian and military sites. And really the purpose of CARE itself is to characterize the natural history of concussion and or repetitive head impact exposure within the first couple minutes to 1 year post-injury. And what's been really cool to be a part of the CARE Consortium myself is that now we're starting to track these individuals after they graduate from college and kind of transition into early adulthood. So now we're starting to track them within the first 5 to 10 years post-college. And really we want to identify some of the potential long-term effects of concussion or repetitive head impact exposure. So the purpose of this specific study was to determine the discriminative validity of individual VOMS item scores and an overall VOMS score to identify concussion among collegiate athletes within the first 72 hours post-injury. First, I want to draw your attention to Table 1. I thought it was just really interesting that there was a larger proportion of concussed patients who reported migraine headache compared to controls, and we can see that in the left and right columns. And this is just an important point when managing patients because we know that migraine headache can result in prolonged recovery. As we move into Table 2, we can see that there are, again, the different components of the VOMS assessment stratified by individuals who were concussed and then their control. And those values are really representing the symptom that they are experiencing during the VOMS assessment here. So we can see that individuals who were concussed were reporting much higher symptoms as well as greater near point convergence compared to the healthy controls. Looking here into Table 3, so this is, again, just identifying the various different VOMS tasks that are included within the VOMs. And then there's something called an AUC. So this is called the area under the curve. Sometimes it's presented in a table like this, and sometimes it's presented in a graph, which I have on the next slide. But really, AUCs are estimated to select the best indicator of discriminative utility and determine statistical significance. So AUCs range from 0 to 1, with values above 50 providing greater diagnostic probability of a test correctly identifying an individual with a specific condition from a healthy control, in this case, concussion. So what we see here, when we look at the AUC values, all of the items of the VOM significantly identified a concussed patient over a healthy control with an AUC of 0.9, except with visual motion sensitivity and then the convergence distance, which I'll talk about why that's probably happening over the next slide. We also see that the VOM's overall score had the highest accuracy for determining concussion over controls. So this is really just showing the clinical utility of the VOMs in discriminating between somebody who may have a concussion and somebody who is a healthy control. Here are, these are just graphs of the AUCs. So here in this table, these were the values. Here we're just kind of seeing again any of the tasks within the VOMs and how they are compared to that 0.50. Again, that 0.50, we want those values to be above to increase the predictive ability of identifying concussion. Within this study, so this is also coming from the CARE Consortium, they wanted to actually create what's called a modified VOM, similar to like a modified BES, because again, we recognize that there are a lot of different components of a concussion assessment as well as management strategies. So if we can maybe modify the VOMs to make it a little bit more feasible for our clinicians, it might be more likely that they can use it. So within this study, they determined that an AUC of less than 0.6 was considered very poor for positively identifying concussion. Those that were ranging from maybe 0.6 to 0.8 were somewhat moderate, and anything that was above 0.80 was considered high and clinically useful, which is again increasing the likelihood of identifying a concussion using the VOMS assessment. The first aim was to determine whether the current VOMS tool can be streamlined without reducing the diagnostic accuracy. Or in other words, how can we maybe remove some of the tasks without sacrificing its ability to identify concussion? So as the research team, again, this is coming out of the University of Pittsburgh, who created the original VOMs, as they were trying to figure out which potential tasks could they remove, there were a couple of things that they thought about. So first, they wanted to think about the overall discriminability of each task, the presence of each task, or maybe like the repeat of tasks, particularly looking vertical versus horizontal, and then the relative ease of the task for the clinician or the patient to actually complete it correctly. They found that the mean near-point convergence demonstrated a poor ability to discriminate between concussed and non-concussed patients. Again, that's where we're bringing the stick or the pen to the tip of the nose. If patients have, maybe they're seeing that blurry vision, but they don't have the true double vision, it might still be increasing their symptoms, but that might not be attributed only to concussion. That could be from some other potential visual disturbances, especially if they're not wearing maybe corrective lenses and they normally do. They also found that both saccades, so it's going to be the rapid eye movement between fingers, both horizontal and vertical, as well as the VOR are duplicated across both the horizontal and the vertical meridians with very similar effect sizes. So they knew that they wanted to remove either saccades or the VOR or make some modifications. They also found that convergence, the near-point convergence, had similar effect sizes as the visual motion sensitivity and the VOR items. So again, that's just kind of increasing or showing the likelihood that there's going to be similar clinical use between all of those tools. As they were kind of working on breaking down these tasks, they ended up with the 4 final tasks based on the criteria I kind of described above. Smooth pursuits, horizontal saccades, horizontal VOR reflex, and then visual motion sensitivity. And those are the 4 that are incorporated in the SCOT-6. And they found that the AUC for all of those were around 0.85. So they had really, really great diagnostic utility. That's what we're seeing in the first graph. Again, we see that like kind of light gray line, that's the 0.50. We want our values to be above 0.50, ideally above 0.6. And to have really high diagnostic accuracy, the researchers established that a priori at 0.80, which all four of those tasks had reached. And then these bottom two graphs, this pertains to AIM-2. So this is to determine whether incorporating maybe a streamlined version of VOMS into the SCAT symptom survey improves diagnostic accuracy between the two tools. So using different domains of concussion to help with increasing diagnostic utility. And so what they found was then they used the mVOMS total score, the mVOMS total scaled to the SCAT Likert scale, that's the 0 to 6 scale, and the VOMS total, so all of the tasks, to determine their predictive utility. They all showed clinically useful levels of diagnostic accuracy with very identical sensitivities and specificities. So what does that mean? Using the mVOMS, so those four tasks, smooth pursuits, horizontal saccades, horizontal VOR, and visual motion sensitivity, with the SCAT symptom survey, improved the diagnostic utility of the SCAT and did not demonstrate different sensitivity or specificity than just conducting the entire VOMS. So it kind of shortens the VOMS assessment. We can see in the SCOT-6, here are those four components of the VOMS. Again, we want to make sure that we're taking that baseline score across those four symptoms. And then going into the modified VOMS, smooth pursuits, horizontal saccades, horizontal VOR, and then the visual motion sensitivity. Again, within the SCOT, there is a blue box, green box, and orange that corresponds to required, recommended, and orange. So you can see that the modified VOMS here, it's highlighted in green. It's highly recommended, but it doesn't have to be conducted every time that you conduct the SCOT. But if you have a patient that is exhibiting some of that dizziness, it might be warranted to run a quick mVOMS to see if maybe some of those deficits may be a result of the vestibulo-ocular deficits. As I mentioned in the prior study, in those four, how they had identified those four tasks, concussion identification may be noted among patients who indicate four or more symptoms on the mVOMS. If you're doing the full VOMS, it's going to be a cutoff score of 2. For the near point convergence, it's 5 centimeters or more. Overall, really the clinical bottom line from this study was that clinicians could consider using the mVOMS with other tools, such as the SCAT symptom survey, to increase the probability of accurately identifying acute concussion. This last study just talks about the risk factors for vestibulo-oculomotor outcomes following sport-related concussion. So the purpose of this was to take a cohort of patients, there were 85 who were recently concussed within the first, it looks like about 10 days or so post-injury. And they wanted to see what were some of the potential risk factors that might identify patients with vestibulo-ocular deficits post-injury. They found that patients with fogginess, nausea, on-field dizziness, photo and phonophobia, so sensitivity to light and noise, as well as headache were at a statistically much higher odds of vestibular and or oculomotor deficits following concussion. We also see that female sex was suggested to potentially influence this relationship. From a biological standpoint, we don't necessarily know why. It could be potentially that women tend to have smaller neck musculature than men, which could maybe cause some additional disturbances when we think about the influence on the vestibulospinal or vestibulo-ocular systems. However, it could also be a more cultural thing where women just tend to be a little bit more honest about their symptoms. Looking at patients who have maybe increased near point convergence, again, we want to see a score of 5 centimeters or greater, which would be indicative of some abnormal scoring. And what they found was that individuals with on-field dizziness, nausea, phonophobia, and fogginess were associated a much statistically increased likelihood of obtaining an MPC distance cutoff score within that abnormal range. So really, when you are thinking about how to use this in your clinic, you should be aware of the increased likelihood of the vestibulo-ocular findings among our female patients potentially, as well as those that exhibit some of these signs and symptoms. These factors could be used to help guide us in prognosis or inform potential targeted rehabilitation for our patients. And what's really great about the SCOTE, the back page, has an opportunity for referral trajectories or management plans if there are other individuals or interprofessionals that need to get involved a little bit quicker to help kind of target the rehabilitation based on the patient's needs. Just to give kind of an overview of what we talked about today, the VOMS tool is a highly reliable, it is valid, and it's great in identifying vestibulo-ocular disturbance after concussion. We know that these disturbances could contribute to prolonged concussion recovery. So if we can identify those early on, it's really going to help our patients in the long run. The full VOMS assessment takes about 5, maybe 10 minutes. I would say definitely no more than 10. It's free to use. It requires very minimal tools. It's pretty easy to interpret. Really, the only tools that you need are a pen, paper, measuring tape, all of those things we have in our clinics. You can use your phone or YouTube to pull up a metronome for the VOR and the VMS. In addition, we also know that it could be used not only for that initial assessment, but also as a recovery management tool. And what's most important, and I think kind of the most helpful for our patients, is it provides kind of an individualized approach to sport-related concussion care and ultimately improve our patient outcomes. The sooner that our patients seek care, the quicker their recovery is among a lot of the contemporary literature that we see. And if we can streamline this a little bit quicker, this is really going to help our patients in the long run. I'm going to go ahead and send you all this score sheet that I made. It gives kind of a nice overview of some of the test components, and then there are specific instructions for each of the tasks that I talked about today, as well as that nice scorecard that I had presented on a couple slides ago. So it's kind of all encompassing. It's a PDF, it's free, and I'll make sure that that gets sent to you following my lecture. Lastly, and if I have any students on the call, I'm sorry, I know I sound like a broken record, but just a friendly reminder, please always make sure to rule out a potential concussion and cervical spine injury with every maxillofacial injury that you evaluate. Obviously, if they get a line drive to the face, we want to address the hemorrhaging head on, no pun intended, but also make sure to think about what's happening behind the hemorrhaging. There's also going to be some forces that are transmitted to the brain as well as in the C-spine. So just make sure that you are consistently ruling those conditions out. Thank you for your time. It is always an honor to speak with you all. I apologize that I wasn't able to make it today. I'm traveling back from the Concussion and Sport Group in Milwaukee, Wisconsin. I'm happy to share any updates to clinical management as they arise. Here is my contact information if you have questions, if you would like additional guidance on how to conduct the VOMs. I have a lot of different tools that I gift with my students, and I'm happy to share with you all. And please feel free to add me on Twitter, where I like to post updates to research, either my own or my colleagues that might be beneficial to you. Thanks so much and have a great rest of your day.